think we're here today to try and inform as many veterans as we can. We're here with Dr. Bash.
Welcome, Radio Land, TV Land, and YouTube viewers and listeners. This is Dr. Craig Bash. I've been doing veterans medical opinions for 30 years, and I have dozens and dozens of these radio shows which we're going to publish on this YouTube channel, and number 1 through whatever. So thank you for listening, and here we go.
Blog Talk Radio.
It's time for the Basser Hour. The Basser Hour is an in-depth look at things affecting today's veteran. The Basser Hour is sponsored by www.hadit.com. If you need help with the VA, log on to hadit.com. Now, here's your host, Jay Basser. Welcome, ladies and gentlemen, to this edition of the Basser Hour. It's been a while. Today is the 5th day of November, so it's on a Monday. It's a special day. Today we're going to continue a series of shows we've been hosting with Dr. Bash and his sidekick, Bill Kreger, and today we're probably going to discuss the big one, TBI. And, that's a very, very serious injury these veterans suffer when they've been exposed to explosions or head trauma. So I'll turn this over to Dr. Bash. How you doing, Dr. Bash?
I'm good. I was going to talk about the prototypical case that we have. The guy recently had a bunch of microtraumas. He was a controller under a 6-inch gun in front of a destroyer, an Aegis class destroyer. And, he has to have health care. He can't walk around. He gets dizzy, gets lost in his house. His wife does all his cooking and stuff for him. So it's kind of a little bit secret, like a secret TBI, because usually people try to look for a concussion where somebody loses consciousness or has bleeding on the brain with MRI scan or CT scan. This kind of thing can be kind of invisible even in MRI scan, but it causes a lot of problems with the person's memory and concentration focus. So I asked Bill to think about something about the ideas between 100% and SMCT, because we have 100%, that pays 100%, but we also have the SMCT that's out there like an R2 level. And there's a lot of little steps in between, so that's confusing to try to figure out how to rate people in those intermediate steps, and so maybe Bill can help us a little with that stuff.
Oh, sure. Sure. Congress gave us a generous benefit for the patients with traumatic brain injury. It was based a lot on testimony by victims of TBI and their spouses who testified before Congress as to the profound disability that they suffer and their severe needs. And I had the privilege of not representing, but I had the privilege of actually deciding such a case for one of the individuals who actually testified before Congress. And,
No way, Bill. That guy testified?
Well, I'm not sure we're speaking of the same patient, but the one I had in mind, I was able to grant the maximum benefit in that case. There were certain activities of daily living that the veteran could not perform independently because of TBI. Part of that was a rather significant impairment of his hands, in coordination, lack of endurance, and so he needed help with some activities such as cooking and dressing. He also had memory problems, and so he was reliant on GPS to get to a medical appointment or to find the grocery store. He wasn't capable of retaining that information. And the Board of Veterans' Appeals had actually remanded that case for further development. And as soon as the case was brought to my attention, I contacted his attending VA neurologist who completed a VA form explaining the need for aid and attendance. Now, the veteran was 100%, and because you're 100% and need regular aid and attendance due to TBI, then special monthly compensation at the highest possible level, SMCT, or Section 38 U.S.C. Section 1114T. That's where it's in the code. That's how it got the name. And that provides the highest special monthly compensation available. It's the same criteria that for other veterans might require SMC-L. That's regular aid and attendance. But if it's due to TBI, it's SMC-T, and it's payable at the highest compensation that VA has available. And so we were able to make that
Bill,
bet
can you
happy.
go over that again? Hey, Bill, can you go over that again?
Okay.
So SMC-L equals SMC-T if the person has TBI.
Exactly right. You got it. Exactly right.
You want to define
SMC-L
SMC-L a little bit for the boys?
Oh, sure. Now, you can find the criteria at 38 CFR 3.350. Okay? And in there, it's spelled out, and the specific criteria are listed at 38 CFR 3.352. Now, those specific criterion are described as the inability to dress or undress, to keep themselves ordinarily clean and presentable, have the frequent need of adjustment of any prosthetic or orthopedic appliance that requires someone else to assist. Okay. Inability to feed themselves through loss of coordination of the upper extremities or extreme weakness. The inability to attend to wants of nature would be a loss of bowel and bladder control. Or incapacity, physical or mental, that is required to protect them from the hazards or dangers incident to the daily environment. So these don't have to be daily needs. They don't have to be severe needs. You don't have to satisfy all of them. Any of them predicates entitlement to regular aid and attendance. The difference is that Congress has given us the authority to grant this at the highest level, SMCT, if it's due to TBI.
Now, Bill, you mentioned the 5-inch gun here, or cannon, repeated, repetitious shooting was the cause of this veteran's TBI, and you was able to prove the TBI through his diagnosis, him having upper extremities, that it was having difficulty controlling?
Well, actually, the Navy did not recognize it. They gave him a rather vague psychiatric diagnosis. In fact, they were at one point exploring whether or not this was a case of malingering, because they didn't quite understand what the cause of his symptoms was. And so they were didn't fit
they kind of gave him this idea.
mold.
amnesia, right, Bill? Amnesia of unknown cause, sort of thing, you know.
Yes,
So
yes.
I saw that, and I go, this is about right. And so I thought he had TBI, and then Bill looked in the record and found some clinical notes, right, Bill?
Yes, there were some clinical notes and some evaluations, and what piqued my curiosity was the fact that had onset shortly after exposure to that concussion and blast on a recurring basis, and because the symptoms had an onset somewhat close to that it piqued my curiosity about could this possibly be an undiagnosed TBI. Now today, in his VA treatment records, he has a diagnosis of TBI. Right, so
it's a complicated issue because a lot of people get treated with nurse practitioners and PAs in the field or on shifts, and unless they see somebody pass out for 5 minutes, they don't think about TBI. They don't have the training to understand that this micro trauma can lead to the same kind of cascade of events in the brain that gives you just as severe mental problems as a major single trauma.
Well, you mentioned this. Here's where I'm kind of getting to here. You mentioned this 5-inch cannon. I don't think it matters whether it's 5-inch or what size weapon. Repeated loud noises in your ears is going to, over time, it's going to do something. However, what I'm getting at is the reaction of their upper extremities. That tells you right there it could be some sort of brain issue. True? And you was able to prove it down to a TBI, and the VA accepted that explanation you was able to give them.
The brain runs everything, So we kind of had two patients there. Bill talked about one, I talked about another, but the concept is the same, The brain has a little body inside it, so it depends on where the traumas are that what part of the body doesn't work. So it's
my point being, could chemicals have the same effects on the brain?
Yeah,
I would think that they could have. Yes.
Yep. Yeah, classic toxin. One toxin we talk about is like radiation. It's kind of an obvious thing that people get radiation to the head and neck, and then that affects the brain. They can get something very similar to TBI because the brain only has so many ways to react. On and off, kind of basically at the bottom level. And things that affect the blood vessels, or things that affect nutrition, or toxins you can get across the blood-brain barrier, can have this very similar kind of, anoxia, low oxygen, too much radiation, too much chemotherapy. All that stuff can leave you with a very similar picture.
Yes, that's the point I was trying to make. This could be a new avenue for a lot of veterans dealing with exposures.
Hey, Bill, what is the rating schedule deal with that?
Oh, there's a specific rating for Parkinsonism or Parkinson's disease, and of course that is presumed to be associated with exposure to herbicides.
True.
That might be something folks need to be aware of.
So, Bill, can some of these toxic exposures get rated analogous to brain trauma?
Not generally. The manual makes it very clear that for rating purposes, a traumatic brain injury means a physical disability resulting from an event of external force causing an injury to the brain. Now, the one alternative diagnosis could be anoxia, if the individual suffers a loss of respiration and the brain suffers from the lack of oxygen. That anoxia can produce symptoms similar to TBI. In that circumstance, if it's service-related, then it can be evaluated similar to a TBI, depending on the global presentation of symptoms. If you're evaluating, yeah.
Oh, what you're saying is that normally you have to have some kind of external blow, but there is sort of a footnote that allows anoxia to be rated into the TBI category, basically.
That's correct. Yes. If it's to be a TBI, it has to be from external force. But if it is from anoxia, you need to choose whichever diagnostic code or diagnosis would provide the greatest compensation to the veteran. You could rate it similar to TBI or perhaps a stroke, a brain hemorrhage, a mental illness, or if it results in some malfunction in a specific nerve distribution, you can rate the nerve affected. So there's a lot of flexibility in the rating schedule to allow for other brain conditions and to evaluate them.
Okay, but anoxia would be one a term you'd certainly want to incorporate in on a claim for not for TBI, but for Parkinson's-like symptoms or what have you.
Yes, and you know, in the more general term of brain injury, as opposed to traumatic brain injury, that would be a reasonable presentation. It could be strangulation, carbon monoxide poisoning, diving accident. So there's
chemical exposure.
Well, another place might show up is somebody who has a seizure, for example. You know, so if they seize and they might stop breathing, and they might get anoxia. And if they had bad enough chemical, you know, back to your point about chemicals, if you had a really toxic chemical, you might get the brain into a seizure state, and it could result in anoxia that way.
Yeah, and you'd want that case reviewed by someone with a substantial degree of experience and training. In fact, evaluating TBI, inexperienced raters are not generally to be assigned the case. The manual requires that a rater must obtain a second signature on a TBI case until after they've achieved a certain degree of experience and satisfactory quality of their work on TBI cases, and then they can rate them independently.
Well, I know some of your TBI cases show up on shows lesions on the brain, but and what you're referring to don't necessarily do that. So the other symptoms they have to go to is evidently your Parkinson's type event, symptoms, or possibly others. You mentioned seizures, which would be, I would imagine, be a good example.
I can see that. Sure. There's I think some of the things that concern me from my experience is, the patient doesn't know. They're not aware, and sometimes it rather takes someone observing them to bring the fact that they have symptoms to the patient's attention in some cases. So it's particularly if the condition results in complex partial seizures, or what's also been called pseudo seizures. When we think of seizures, we picture a grand mal type of event where the person is collapsed and shaking on the ground.
Yes.
That's sort of the severe sort of an event. But there are other types of seizures, and these complex partial seizures can result in some pretty strange and hard to detect sort of symptoms and presentations. I had a patient who took his family to the beach, and he and his wife and child were there, and he stood up and pulled off his swimming trunks. And his wife was fighting him to pull him back up, and he was fighting her. And then after the event, he had absolutely no recollection of that at all. And that's just one example. There was a time when he took a carton of milk out of the refrigerator and poured it in the closet. Another incident where the same patient, they were at an outdoor restaurant, and he got up from the table and walked straight into a highway in traffic and caused cars to screech their brakes and everything. And I remember very distinctly at a hearing, he was trying to achieve service connection and get an evaluation. His wife testified to all this, and he flatly denied that it happened. He had no recollection of any of these events whatsoever.
So he did it more or less on an involuntary impulse. He just had an impulse to do something, and he wasn't aware of it. It was like an automatic response to something.
Exactly right. Exactly right. It was a very odd case, and
that would be a tough one. Yes,
it certainly did make an impression on many. But we were able to get him well cared for and properly evaluated. I was very glad when that happened.
Well, that would have been a tough case to win.
Yeah. Back then I was representing that individual, and we had a sympathetic hearing officer to hear the case. I think that had an impact on the case too.
Well, yes, and it helps to have someone understanding like that. Have the ability to see the possibility that this can really happen.
Yeah. It takes good documentation, good witnesses, and a good medical explanation to help the adjudicator understand the medicine, because it's not something you're going to typically find in your records.
That's true.
But it might be rather important also to point out that some conditions arise secondary to TBI, and certain conditions in certain circumstances are presumed to be associated with TBI. You don't have to prove it, like Parkinson's, or seizures, or dementia, depression, sometimes hormone deficiencies. So these sort of things are very important to be aware of. You don't have to prove them. Now, if you don't quite satisfy all the rules for presumptive service connection for a condition, you can be service connection on a secondary basis by proving the case with medical evidence. So if some condition is determined by a competent medical source that it is secondary to TBI, then VA can grant secondary service connection and evaluate it.
Well, wouldn't that usually take a sympathetic adjudicator? I mean, like a DRO or someone that can understand, have a better understanding that these things are possible.
Yes, and I think that's why VA has limited those who are permitted to make an independent decision on TBI cases. In that way, the veteran with TBI has the case reviewed by someone more experienced and having already demonstrated the ability to sort out these kinds of issues.
Thank you all for listening. That ends this show. And now I'm going to zoom off.